Friends, we are today having a presentation on the art and science of ensuring satisfied patients post-cataract surgery. Majority of us do good cataract surgery, but it is not just merely operating and giving a good result that satisfies the patient. There are many other aspects related to it, which ultimately lead to a satisfied patient. Getting a vision of 6.6 or 6.36, it's no a criteria which one is going to be satisfied. There are many other, as I said, aspects to it, which will lead to ultimate determination of how the patient is going to be retained by you or is going to go somewhere else. So starting with the IC, first topic is patients' expectations and how to handle them. Dr. Sumit Sachdeva is going to make this presentation. Dr. Sumit is a professor of ophthalmology at RIO PGIMS Rohtak. He's a national level faculty as well as an international level faculty on glaucoma. He has done presentations and workup classes at Singapore and other countries for in glaucoma. He is a very versatile surgeon. I can vouch if anybody want to get operated in Rohtak, he's the man to go for. Besides being a great surgeon, he's also a great friend. And now I want Dr. Sumit to please start his presentation.
Thank you, Dr. Vikram. It's a pleasure to be here amongst you today morning. And I thank Dr. Vikram for conducting this IC on happy patient outcomes. A very important topic for all of us, because all of us want our patients to go happy and satisfied. But what all takes to make it happen, that's what we are here for. So I'll be talking about patient expectations and pre-operative counseling. Now, we all know that cataract surgery is the most commonly performed ophthalmic surgery worldwide. It is mostly very safe, but yes, the complications do occur and they do happen. And the patient counseling has all these implications. It has a medico-legal implication also, because you have to explain everything to the patient. It is good for the morale of the patient and ethically justified. So a proper counseling is all what is required. Now, the cataract surgery has evolved from being a vision restoring surgery about a few years back to the eagle vision concept. The patient wants everything in one go. So this is what the patient's expectation is from us. And to ensure happy patient outcome, it all depends on the work profile and the visual demand of the patient. What is the age of the patient? The economic status, very important. Any comorbidity, or the personality types, how the patient is. Now, how does a cataract patient comes to our OPD? He comes to us with either diminution of vision, has some work-related problems like during driving or during reading or during watching something on television. Then they are mostly, sometimes they come to us with as referral patients also by some optometrist who has done their refraction somewhere outside, and they are referred to us from that place also. So these are this is the profile of how the patient comes to us. And now, if the patient is told directly that, yes, you have cataract, his reaction depends upon the age and the stage of the cataract. Now, the age means that if you tell it to a younger patient, less than 30, 35, 40, then it's very hard for him to take that, yes, he has started developing cataract at this stage. Or if you tell it to a person who is already an old patient who is expecting this to happen, so it's very easy to convince him for surgery or to tell him that, yes, this is what is required. And of course, the stage of the cataract, if it is a hard, mature cataract, the vision is almost lost, the patient is much more easily convinced to get it done. While if the patient's vision is almost okay and it has just started, so it's quite challenging to make him understand that, yes, you require cataract surgery because your work is being hampered. Now, what are the expectations of the patient? The expectation is to have a clear vision, so that he can perform the near, intermediate, and distant activities with ease. And he's comfortable during nighttime and can perform the day-to-day activities easily. So this is all the patient wants, which is basically all what we want also. And but as we all know, cataract surgery is not a magic. So why is this counseling important? Counseling is important because it respects the patient's autonomy to make a decision, to be convinced that yes, this is what I require. He has the right to make the correct decision. So it is your responsibility to tell him about everything that is involved in a cataract surgery. Cataract surgery might be a routine procedure for you, but for the patient, it is very, very important because it's his eye and it is going to be operated only once, most of the times. So you have to weigh the risk to benefit ratio if there is some risk factors involved. Then you have to allay the patient's fear. The counseling is important to allay the patient's fear, and it ensures realistic expectations of the patient. So a very important part of your cataract surgery is the counseling. Now, to counsel a patient, first of all, you have to convince yourself what is the best treatment option available for the patient, keeping in mind his eye condition, the age of the patient, the pocket of the patient, very important, and his expectations. You have to discuss various options and expected outcomes. Be very clear and realistic about your procedures, about his expectations, and you have to be very clear about it. And discuss the potential risk factors. If it's a complicated case, you have to tell everything. You don't just promise the moon to him. You just tell him that these are the risk factors involved in the surgery, and these can be the limitations. What is covered under counseling is that what does the cataract surgery involve? How are we going to, for the procedure, whether we are going for a manual or a phaco, whether it's, what is the pre-operative assessment, what is the type of the anesthesia that we would be using, maybe it is a general anesthesia, topical, or a periorbital block, which surgery is being offered, is it normal phaco or femto or the ECC, whatever. Then post-operative care and duration is very important. The patient wants to know when can I get back to my day-to-day work. So that is very important that you have to tell him that this is the time that you would require for the recovery. And then what benefit does it do? It creates a less anxiety in patients. The patient is more self-confident. He has a better relationship with you once you talk to the patient. You just counsel him. Then it regains its emotional balance. There is increased assertiveness by the patient also. Stress is relieved. And he's able to set the boundaries that, yes, this is as far as I can go. And there is no trauma after the surgery has been done. So this all helps the patient to be more confident and more sure about himself that what he wants. Now, what more you can cover? Besides the type of the surgery, you can cover the type of the IOLs that you would be using, whether the premium IOLs or the normal ones, what is the expected outcome of them, what is the recovery part, and most importantly, what is the cost of the surgery. Now, to assess, to have a healthy or a good outcome, these are the pre-operative assessments that you need to perform. Like, just don't look at the cataract part, look at the other things also, like lid hygiene. What is the cornea status, whether there is any opacity which might hinder the vision later on. You have to tell it beforehand. All has to be seen on a slit lamp. What is the AC reaction? What is the pupillary reflex, whether there is any RAPD or a subtle reaction which is out of normal? What is the grade of the cataract? What is the vitreous? Are there any vitreous problems? I've seen people with asteroid hyalosis coming later on and with visual disturbances. So we have to tell them beforehand that, yes, this is the problem and you might have some problem later on. The proper retinal assessment is very important. And if you can get an OCT done beforehand, that would help if it is not there, but your clinical judgment should be there. And the macular function. The simple tests are there which can be done. The type of surgery that what we are performing nowadays are phaco, femto, SICS, ECC will be discussed later on. The type of IOLs, monofocal or multifocals, hydrophilic, hydrophobic, aspheric or spheric, plain or toric. Special situations like phakic, scleral fixated, and CTR, they have to be explained to the patient. Now, who is not an ideal candidate for premium IOLs? This is very important. We are very, premium IOLs bring a lot to our practice, and we are ready to offer them to anyone who comes to us. But those people who strictly do not want to wear spectacles, they are not ideal candidates. Yes, you have confidence in yourself, you can perform the best surgery in there, but still there are people who are not satisfied with the outcome. So, who strictly do not want any spectacles, they are unwilling to adapt, they have unrealistic expectations, and they have abnormally long or short eyes, then we have to be very careful in prescribing premium IOLs or the charges accordingly. What is the expected outcome? It depends upon the pre-operative condition of the patient. If the patient has some problem in the retina, yes, the expected outcome would not be there. What is the comorbidity? Are they suffering from any condition like diabetes, AMD, and the type of the surgery which has been performed also has an expected outcome. It affects the outcome. The common post-operative problems have to be explained to the patient in his language, that yes, there can be slight pain after surgery, there will be some redness, there can be some itching, foreign body sensation, and watering. These are the most common complaints that the patient comes to us or calls us later on, sir, aankh mein radak ho rahi hai, pani aa raha hai. So this is what we need to explain to this. This is common, this is normal. Patient is much more confident about himself. Then post-operative care, you have to advise about proper hygiene and restrictions. Be patient with the patient's problems. Reassure him and be willing to make the change because it's his IOL, and just advise him that yes, all is well, don't worry about it. These pamphlets, yes, definitely do help. If you have them, that is very good for the patient. So my carry-home message would be that proper counseling plays a very important role in happy patient outcomes. Tailor the counseling according to the individual needs and his expectations. Be very realistic and under-promise and over-deliver. You will have a very, very happy patient and he will be eternally grateful to you. Thank you so much.
Thank you, Dr. Sumit. That was a good overview of the patient's expectations. I'll just like to add, yeah, Dr. Soma, you please sit. Till Dr. Soma takes the dais, there are few things I'd like just to add to it.
Yes.
What Sumit properly mentioned, that patient counseling pre-operative is important. We do have counselors in a setup who counsel the patients, but what he actually said, the first counseling should be done by the doctor, because howsoever learned your counselor may be, but he's not technically, clinically that strong. So a doctor giving the first counseling is really important. So one more important thing I'll add from my personal experience, the first reaction to a diagnosis, especially for the young patients, 35, 40 years, who come with PSC, they have some vision problems. And then all of a sudden you tell them, yes, you have a cataract. If you just straightway go and tell them it's a PSC and you'll have to get it operated, believe me, 99% of those patients will never come back to you for surgery. Tell them, boss, you have a cataract if you want to retain your patient. Yes, you can wait for some time, but slowly it's going to progress. Let's see how much time it's going to take. Because I have personally experienced those patients whom I would say, boss, you have a cataract, get it operated, I never saw them again. And those who had been seen by someone else prior, and he had told them the same language I told, ki, boss, you get it operated, they were getting operated for me. So I inculcated that practice, and now, whenever a young patient is there with a cataract, I say, yes, you have a cataract, but I hope it's going to take some time to progress. In the meantime, there's nothing better than a lens given by a God. Let's try and see it, and in the meantime, troubles you more you come. And those patients come back to me for surgery, even after 6 years, 10 years. So this is how the patient are retained, and then they are satisfied with you. That is, I would put it like a counseling or pre-operative assessment or diagnosing first time the cataract. And one more thing, as I told about pre-operative AMDs or asteroid hyalosis, I like to add a point, Sumit, here. Posterior polar cataracts, I always do tell my patients, see, this is a posterior polar cataract. This is one of the worst type of cataracts. We handle most of them very nicely, but in few odd cases, you can have a nucleus drop. And if that happens, then I'm already pre-warning you. I'm just not responsible for it. I'll guide you. I'll get it operated for you. But then you'll have to handle the cost yourself. I always tell that point very clearly. And I tell you that removes a lot of burden from my mind. I'm operating more freely, and we really get good results. What do you say, Sumit?
Yes.
Amit?
Yes.
So posterior polar cataract, I mean, you have to be very careful. You have to counsel the patient pre-operatively. Like my patient, if he has a posterior polar cataract, I tell him clearly, I might not be able to put the lens in the same sitting. If your lens can drop down, I might need a you might have to undergo a second surgery. I might not use the lens which is promised. I'll decide on the table which lens is best for you and I'm going to utilize it. So I explain all these things, I write on the file and I take the patient's signature also. And so the patient and the attender has to sign the consent, and there's no harm. You tell him that doesn't happen, the chances are rare, but if it happens, this is the treatment protocol I'm going to follow and I want to make you aware, and the acceptance is very high after that. So yeah.
So our next speaker is Dr. Samia Ganesh. She's a cataract surgeon and a director of the Lopamudra Drishti Eye Center. She is a author and literature review of many national as well as international journals. She has been awarded many national levels and plus international levels awards. There's a long list to it. Samia, you don't mind if I skip all of them, huh?
Absolutely.
She has been awarded ESCRS, World Ophthalmic Congress, and Asia Pacific Society, multiple international awards. And moreover, apart from that, she is a yoga instructor. So that is a feather in a crown. I really appreciate such thing, not just working, taking care of your health is really important. So I'll request Dr. Samia to speak on pre-operative considerations and IOL selections. Dr. Samia, please.
Thank you, sir, for your kind introduction, and also thank you for including me to be part of this IC. I'm very glad to be here amongst all of you today on this early Sunday morning, and hope it's a good one. So I'm going to be speaking on pre-operative considerations, including IOL selection. The most important part in cataract surgery, we all know, is to establish a rapport with our patient. So how this starts and how this is established really influences the whole experience that the patient has with us as, as patients, and then maybe as friends, as a colleague, as whatever. So the most important part is to make sure to make a good first impression. So the feeling the patient has while they're waiting to meet you, the ambience in your waiting room is extremely important. So we must pay attention to that. So this is the first impression that the patient gets about us, and it has to be a good one. The way the staff behaves with the patient really makes a great difference to how the patient experiences this whole process of meeting you and going back. So that has to be on spot as well. Having to wait to be seen is often a patient's number one complaint, so we must make sure we are always on time as much as possible, and it's very important to prepare our day plan and our schedule accordingly. It's very important for us to know something about the patient before the patient walks in, because that sense of familiarity goes a long way in kind of making the patient comfortable with you. It's very important to spend a lot of chair time before surgery, otherwise we'll be doing all that explaining after. So we must make sure everything is explained to the patient prior, like Dr. Sumit just told us. And also, like we discussed, when we are told a sudden diagnosis that we're not expecting, it can come as a shock. So sometimes it's good to reassure the patient about the seriousness of the condition or the treatment options available in a friendly tone, in a compassionate tone, but also very important to be formal at the same time. So I think that is something we all learn with practice. Those are soft skills that we pick up over time. But it's very important to make the patient feel comfortable and then take it forward from there. So examination, we know, is the absolute basis of our cataract surgery. It's very important to do the non-touch procedures before the touch procedures. For example, it is important we do the keratometry and topography before we do something like immersion or contact IOP testing. It's important to do a bilateral examination always. There is no compromise on that because sometimes we may miss something that can really influence the outcome. The vision must always correlate with cataract. So over the years, we've all come to some understanding about how the vision should be for a particular cataract. And if it is not falling in place, we must take that extra time to make sure we go through everything that could be influencing the surgery. And even if you do not find anything, it is important to communicate this to the patient that it is not correlating, and to let the patient know that further examinations may be needed. Examination on day of surgery is ideal, so NABH requires us to do this as well. But sometimes in busy practice we may leave it out. But ideal case scenario, we must be examining each patient on day of surgery as well. So it's very, very important to look for potential sources of infection. I think this is the most basic thing we've all done starting from our post-graduation to look for infection sources like, we do our syringing. It's also very important to look at the general hygiene of the patient. And even if it's uncomfortable, we must address these things and communicate these things to the patient. Look out for blepharitis and Meibomian gland disease. Blepharitis quite often, can hold a lot of infection load, and we must address these issues beforehand, because we don't want to be breaking our head about this if something goes wrong after surgery. And I do a syringing for 100% of my patients, so it's very, very important to look out for chronic dacrocystitis as well. Of course, I don't have to mention that there has to be a very detailed anterior segment examination, whether it's the health of the endothelium or the depth of the AC, the type of cataract. These are very important, and it must go through a stepwise format for each patient. I treat 100% of my patients for shallow angle if they have it. So I don't want to take a chance on the day of surgery. So I make sure shallow angle is handled as well prior. It's very important to look for complicated situations like posterior polar cataract, like we just discussed. So I'm not going to go into the details of that. Dry eye is becoming a very important cause of unhappy patients with time, now that we're using more and more premium IOLs, and now that the expectation of the patients are going up. And with our current modern day life, all of us, I think, have some amount of dry eye, maybe on a daily basis or occasionally. And same with our patients, they're all using digital devices. So dry eye is a part and parcel of our modern life. So we must address this before surgery. We must look out for it, treat it, also advise about post-operative dry eye and handle it accordingly. So not only does it influence our post-op outcome, it also may influence our pre-operative findings like topography or keratometry, because dry eye can change the topography to some extent. Not to miss the posterior segment, very, very important to do a dilated examination in all patients. Sometimes, if the vision doesn't correlate and you do an OCT, you will find that there is some ERM or some slight macular edema which we may miss on examination. So it's very important that all patients must be dilated. And if you're not able to see the fundus, it's very important to take a special consent saying the fundus is not visible, and then we will need to explain to the patient as well. So biometry, like I said, it is very important that this has to be bang on. Nowadays, most biometers are really good, so we're lucky in a way, and we're fortunate in a way. We're in a time where biometers are giving us such excellent results. It's very important to do our non-contact procedures prior to the contact procedures, like I already mentioned. We must look for astigmatism and treat it, and if we are not treating it, the same must be explained to the patient. And of course, until the whole examination is complete, we mustn't start talking about IOLs right in the beginning, When we're sure about the whole status of the eye, the fundus and things like that, then it is the right time to discuss about IOLs. And so, like I said, if there is some amount of astigmatism, let's say anything above minus about 0.75, we must start talking about toric IOLs, because toric IOLs are one thing that can be bang on and can give so much satisfaction to the patients. And then when we are choosing between multifocal and trifocal, of course, it's a different ball game. Now there are extended depth of focus IOLs available as well, and this has opened up our the opportunity of giving some amount of near and intermediate visions to a lot of patients who may not have been suitable for multifocal and trifocal prior. Between contact and immersion, of course, we should opt for immersion. And if an optical biometry is available, then this is even better. And of course, all myopic eyes ideally must have an optical biometry, because this checks the line of sight. Pre-operative considerations for multifocal or trifocal IOLs, apart from everything else that we've discussed, is a strong desire for the patient to be spectacle free, and an understanding about the situations that may arise, the understanding that there may be some need to use near addition. The hypercritical and demanding patients, we must always be careful and do not overpromise anything to these patients. In fact, do not overpromise anything to any patient. And of course, also explain to the patient that there can be some intraoperative situations which we may not anticipate and which may happen anyway, and then it may or may not be possible to implant a multifocal IOL, especially in these patients. They should know. it's very important to not oversimplify the procedure. You know, I think especially in cataract, we've come to a situation where we are selling it as a very simple procedure, but it's not, because we are, you know, undergoing the whole stress of having to do the surgery, and we're trying to make the patient stress-free. But it's very important that the patient takes equal responsibility for the procedure and the cataract as well. For the situation, it's not something that we have created. It is a problem that the patient has. The patient has to understand that. I will never tell the patient it's a simple procedure. I will say it is an intraocular surgery. It is it is something we open up the eye to do. But because we have advanced to such a good level, we are able to do it in a very comfortable way for the patient. But it's not a simple procedure. It is a surgery, and the patient has to understand that. We put in so many years and so much money and so much effort, so much time into making sure everything is sterile, so some responsibility has to come from the patient. Once everything is over, if the patient is still unhappy, we must be able to listen to them. Sometimes they just want us to listen and to be told that we are there to help them out. Very important to document everything. If there is anything that is may cause a problem, it is very important to explain it prior and never be in a hurry to operate, and just be sure that the patient understands what is happening, you understand what is happening. I mean, in today's day and age, unless you're in training, it's better not to experiment something that we are not sure of. Pricing quite often can be a bone of contention, so this has to be very clear right from the beginning, and informed consent to protect ourselves. So I'm from Coorg. This is where I practice. You're all most welcome to visit Coorg, and have a nice Sunday. Thank you.
Thank you, Dr. Samia. That was really precise and to the point. Now I'll request Dr. Saurabh Mittal to present on ocular surface management for optimal outcome. Dr. Saurabh Mittal is a pediatric as well as cornea fellow from Arvind, and he is practicing in Jalandhar with Thin Eye Hospital, and he's dealing in all type of anterior segment surgeries, maybe from transplants to pediatric ophthalmology to cataracts to LASIK. And Dr. Saurabh is going to throw light on a very important aspect which is usually neglected. Dr. Saurabh.
Good morning, everyone. Thank you, Vikram, for including me into this instruction course. So, this is a very important topic, dry eye in any field of ophthalmology. 80%, 75 to 80% of all of us do have some amount of dry eye. It can be mild, moderate, severe, or maybe worse than that. So what happens is, if a patient comes to you and if you ignore this particular finding and you do surgeries or whatever, or someone else does a surgery in your hospital, you have to finally face this problem. So I, being a dry eye specialist in my clinic and handling these patients, I frequently see so many patients, they are unsatisfied, they have good vision. Post-operative results in our hospital are excellent. We do have all type of equipment to make that possible. But this unsatisfactory levels are so high. See what happens once the patient enters into your clinic. This might happen 2 weeks, 3 weeks. Up to 2 weeks you can explain, but after that it's very difficult. So there is a patient. This patient comes to our clinic. Both eyes were operated. See, right eye, when we did the surgery, it was very comfortable. But when she underwent the other eye surgery, the main complaint was there is an explosive which has been fitted into my eye. Vision is good, but explosion because of the burning, of the irritation and whatever hard feeling they had. And she was like, every visit she used to complain. And finally she landed up with me. So what we did was, we took her to the set of examinations to see exactly if she has anything else, especially this mist thing, the dry eye. So we found that her tear film breakup time was in the right eye was less than normal. Shimmers was fine. Lipid layer analysis was done, which showed that the lipid layers were on a lower side, 41 in the right eye and 45 in the left eye. See, left eye was also not very good, but still there was no complaint from her on her side. When we everted the lids and looked for the Meibomian glands, we found that there was severe amount of MGD dysfunction. So this has to be seen before the surgery has to be done. At least we can explain to the patient beforehand, so that the level of satisfaction and the communication what we'll have with the patient helps us in giving her a better result. So why we miss this dry eye? See, patient is ignorant. Patient does not know anything when the patient lands up into our clinic. He just says vision is less, and rest everything he will forget or she will forget. And we also are most of the times ignorant about the dry eye disease. So patients, why we are ignorant? Because patient symptoms are variable, nothing to severe. Patient might not feel anything over a period of long time. And we also ignore it. If she is fine, then nothing else. Just go ahead with the surgery, because cataract is going to give you a lot of money. Identifying a dry eye probably might not do that, gives you that much of economical satisfaction. Now these symptoms, they vary from time with work and environment, and we do tend to miss some subtle signs when we are examining the patient. For in case we just ignore the pingecola and we just look into the pterygium. So we are ignoring some simple signs on the examination. Watering is a very common problem in dry eye. So patient will have reflex tearing. So patient will always say watering hai. So, and once the watering hai is, means that there is some amount of dry eye inside the eye. So, and there might be some other ocular diseases which are associated, and there might be no disease at all, especially in cases with refractive lens exchanges. So I call dry eyes to be an invisible disease. We have to look for it. If we find it, we can treat it, and we can make our patients comfortable. So what can we do to avoid this unhappy dry eye scenario? We should identify the disease, and this should be done preferably before the surgery, not after the surgery. And once this is identified, we should be counseling the patient that you have this particular problem and this has to be treated. Probably you can get it done before surgery or maybe after surgery. It's up to your choice. So now, what is dry eye? Dry eye is a universal phenomenon. It happens with everyone, almost everyone. Its prevalence is more, 10% with every decade. It increases. And the severity also increases with age. So more our age, the more the cataract, more the dry eye. So everything fits into a particular group of patients who are undergoing cataract surgery. And it's more common in female and in Asians. Here I've highlighted females especially because most of the complaints, they come from the females, because they will be sitting idly at home, not working, and being a housewife, they will have some amount of irritation, and they are more open to talk to the doctors than the males. There might be severe, the severity is also more with associated diseases like diabetes and autoimmune diseases. Ocular comorbidities like glaucoma medications, they tend to increase the dry eye. Surgical factors, what type of surgery we are doing. We are doing the way we are doing SICS, or we are doing phaco's, we are doing clear corneal, or we are doing scleral incisions. What is the amount of area inflammation before the surgery. Post-operative medications like steroids, they are going to aggravate our dry eye after the surgery, probably because of the particle matters getting clogged into the Meibomian glands, or the steroid itself increasing the inflammation in the along the lid margins. Poor hygiene. We advise most of the patients not to splash water into the eyes, and they don't listen to the second part, that you can do clean your eyes after 2 weeks. They don't listen. They just follow this particular phenomena, maybe throughout the life, that we are not supposed to touch our eyes once the lens is inside the eye. So they don't clean their lashes, and this increases the risk of infection, also increases the incidences of dry eye. So environmental factors like peak summers and harsh winters, they do have effect on dry eye. They do lead our eyes to become more dry. We have now plenty of activities which has decreased our incidences of blinking, like prolonged reading, mobile work, working on computers. Along with that, if we are working in a low humid environment, like in air conditions, or with forced heating or forced cooling, that also leads to aggravation of dry eye. Now, in this particular dry eye scenario, 80% of the cases are because of the disturbed lipid layer. And that is because of the decreased Meibomian gland secretions. So this particular group of patients I am highlighting because they are all treatable patients. They are not the patients which we cannot manage easy. They are easy to treat, and they are the most genuine patients who can give you a very good result after surgery. So we know about what are the layers of the tear film. mucus, aqueous or oil. In simple terms, we explain it to the patient like you have a sticky material, aqueous or water material, and the oil layer. So oil layer is the one which is disturbing you. Along with that, we should also be looking on the ocular surface and the lid margins for understanding the whole disease pattern. A very simple questionnaire is given to the patient because these type of patients, they used to come. So we have now incorporated all these things what we are going to highlight now into our daily practice. We try to identify dry eye before we advise any patient for undergoing any type of surgery, maybe it cataract or LASIK or any other surgeries. We ask the patient for simple dryness, grittiness, scratchiness, irritation, burning, watering, eye fatigue. It takes hardly less than 30 seconds to inquire about the symptoms. And are these symptoms there from what duration is there of the symptoms? If the symptoms are frequent or if the symptoms are there from long time, in that we make up a question. This questionnaire will give us a value that will be considered to go for a further investigation or not. If the value is more than 6, then we go for a further evaluation. So what are the further evaluations that we do? We do look for tear film breakup time, Schimmer's test. If you have the facilities for lipid layer thickness analysis, you can go for lipid layer thickness analysis also. You can do a corneal staining, and you have to do ocular and systemic examination to rule out other ocular comorbidities which can affect the dry eye. So if T-bud time is less than 10 seconds, that is considered to be abnormal. We should be looking for this functional capacity of the tear film. Schimmer's test we can do at all our clinics. Less than 5 is severe dry eye, more than 15 is normal, in between is borderline. Ocular staining, looking for epithelial defects or conjunctival staining. This indicates that probably there is a loss of goblet cell and the mucous layer is gone. So Meibomian screen, we can press the Meibomian glands with our finger. The pressure should be gentle enough, it should not be very hard. And if you see that there is a clear fluid coming out through the Meibomian gland, this means it's fine. If the fluid is not clear, it is like a toothpaste material, this means that dry eye is going to be very severe, the secretions are very bad, and we have to treat these patients. We invert the lid and look for the Meibomian glands. If you have the screening modules, you can do it with the help of them. And if you find that Meibomian glands are shortened or they are absent, then we do have to tell the patient that you are going to have some irritation feelings after the surgery, which are going to get aggravated with the cataract surgery. So these are the, I'll take another 2 minutes. If the lipid layer analysis is done, you might find this rainbow type of pattern on that analysis. If the rainbow pattern is there, this means that there is a good layer of lipid, and the pattern is not there, this means the thickness is on the lower side. So disease counseling has to be done before the surgery. Patient should be made aware of the disease. They should be told that the treatment is required. They should be explained that surgery might aggravate the disease, and the different treatment modalities should be discussed with the patient. So before cataract surgery, a well-educated patient, aware of his disease, is the least unhappy patient. At the time of discharge, if we tell them, at least we can make him more comfortable by giving him some reasoning. But after 2 weeks or later, if we tell them that you have a dry eye, which we have not diagnosed earlier, he is going to be very unhappy with you, and he might not turn back, even with the treatment also. So treatment options, all we know is artificial tears, immunomodulators like Restasis, hot fermentation heat pads, punctal plugs, intense pulse light therapy, and LipiFlow. And there are so many which are coming in the pipeline. So disease management, if there is aqueous layer deficiency, we do go for artificial tears and punctal plugs. Lipid layer defects, we can go for oral doxycycline, hot fermentation, MDD expression with LipiFlow and IPL. Mucous layer defects, we go for cyclosporin, autologous serum, and anti-inflammatory agents like steroids. Meanwhile, our lady which complained in the beginning, what we saw, we used artificial tears as a routine. We advised her to go for hot fermentation once a day. And we did gave her the intense pulse light therapy, one sitting with manual expression of the glands. And she was reasonably comfortable after 2 weeks. All that explosion has gone from her eyes. And after that, she never returned. This means that she was very comfortable. So I thank all of you for sparing your time this Sunday morning. And if you have any questions, you can ask, please.
Thank you. Thank you, Dr. Saurav. Saurav will take the questions at the end, right? That was really very precise. And one very important aspect which Dr. Saurav has highlighted, it's regarding the more complaints in the females, especially because there are a lot of hormonal changes just around the perimenopausal and menopausal age, and that leads to more of dryness. Our next speaker is Dr. Amit Porwal. He doesn't need any introduction. He is a member of the scientific committee of AIOS, and he's head glaucoma at Choitram Hospital, Indore. And he is international level speaker in nearly all international societies and forums. Dr. Amit will talk about perfecting the operative art. Amit, please.
So, thank you, Vikram, for making me a part of this institutional course, and thank you, our delegates, for coming all the way in the morning for the first session. So, I'm going to talk about perfecting operative outcomes. So, what is perfecting operating outcomes? How are we going to master them? So, masterly and timely management of intraoperative steps is essential for happy and satisfied patients. So, to have a perfect surgery, what all things we have to take care, where all important points which have to be considered, I'm mentioning in this block. So, while you are giving a block, you make sure what you are comfortable with. Don't go by what your friends or colleagues or your practitioners are surrounding you do, whether they do a topical, peribulbar or what. You decide with what anesthesia you are comfortable, and you do the surgeries with those only. Coming to the next step is incision. The length and width of the tunnel is very, very important, whether it is the main tunnel or the two side ports, because that is every step in phaco is going to affect the next incoming step. So you should concentrate on the length and width of the incisions which you are making on the cornea or the limbus. Capsule management is very, very important. Two important tips is, what I feel is you should always stay in the anterior capsule. Why? I'll tell you in the first videos which I'm going to show. And you should be aware of all the CCC techniques which are available, which are mentioned in the textbooks, and there are some modifications of the rexes which are mentioned in the literature where studies have done. So you should know all the types of CCC techniques. You should be able to know when to use a visco adaptive, when to use a visco cohesive, or when to use a combined. You should know all the chopping techniques. Again, don't go by what people say कि मैं तो सिर्फ direct chopping करता हूँ. No, whatever you are comfortable with. Even a direct chop or divide and conquer. The first step of a chopping technique is divide and conquer. Even divide and conquer does give an excellent result with least endothelial cell loss if it is done in a proper way. Coming to the cortex wash, I'm going to tell you how do we do the cortex wash. Iol loading and insertion, you have to pay important stress on the temperature, the visualization of the lens inside the cartridge, and at what angle you are inserting the Iol. That is very, very important. Again, washing the visco which is left behind the Iol, how to do it, I'm going to stress on that, and proper wound closure. So I'm just going to demonstrate a small video in which I'll highlight all the steps which I have taken. So you have to stabilize the eyeball and make sure the incision, your side port should not be too long and should not be too wide. If it is too long, when you are doing the bimanual steps, you'll have a lot of wrinkles around the cornea at the incision, and if it is too big, there will be a lot of wound leak, and sometimes there might be an iris prolapse. Staining of the capsule with trypan blue under an air bubble on a 1 cc syringe is very, very important. It gives uniform staining, and by staining the capsule loses its elasticity, and you get a better control of the vector forces when you are doing the rexes. I showed the main incision. You can use a uniplanar, biplanar or triplanar, but again there should not be leak. You should know what is your sleeve size, and based on that you should master your incision. The technique of your rexes. This rexis marker which I showed you on the cornea, it is only for a time being. You just have to indent the rexis marker around the visual axis, and you can see the nice imprint is there, and now this will act like a guide when you are performing the capsular rexis. Important thing when you are doing a capsular rexis is always make sure the AC is adequately filled with viscoelastic substance. You should not overfill it. You should always have a flatter flap, and you should have smaller tears. You don't make larger tears. If you make a larger tears, there are chances of extension, and the rexis marker already gives a guide. Coming to the hydrodissection, you have to make sure that you visualize the wave, and sometimes a multiple hydrodissection from different quadrants and a delineation help you in mobilizing the cataract from the corticocapsular adhesions. Whenever your visuality is obstructed, always use visco. Don't tell your sister to go on pouring saline on the cornea, because that is more epitheliotoxic. So once you just put visco and your view becomes very clear. Again, when you are doing the phaco, important thing to realize is first check the flow outside the eye before you put the phaco probe. Always make sure that the 2 irrigation ports are at 3 and 9 o'clock from the bevel, and whatever technique you are comfortable with. I am more comfortable with my stop and chop technique, and it is not like that I do only stop and chop. I had an IC yesterday where I showed that if you are not getting a good crack, you should not be ashamed to convert into a divide and conquer also. Divide and conquer is not an inferior technique, it is a very good technique. Only thing you have to learn is your tip should be adequately exposed. You should embed the phaco tip into the cataract to get a chop, whether it is a stop and chop or a direct chop. If you don't embed the phaco tip adequately into the substance of the cataract, you will always leave the hold. So as it is said, by doing a short course of 20-25 phacos, you won't be able to master. Important thing to learn and to master your skills and to refine your skill is you always record your surgeries. Whatever surgery you record, you visualize it later on and see where you could have improved. This way, the mastering the surgical techniques will be very, very important, and this will give you a good guide that what is needed. So recording systems are not expensive. Even with 5,000 or 6,000 rupees, you can start recording it. Coming to the bimanual technique, or even if you want a coaxial technique of cortex wash, the important thing we should remember is you should never pull it perpendicularly the adhesions. You should always strip it by giving a bit of diagonal movement so that you don't have any zonular dialysis. Always I prefer the bimanual technique because I don't have to put more stress on the main wound, but if I go with the coaxial, I would recommend a J cannula so that the subincisional cortex can be aspirated without much stress. Now coming to the injecting the IOL, you should have adequate depth AC tightness. If it is too tight, the IOL the visco will go on coming out and you will have more resistance. You see in this, when I was injecting the IOL, the direction of the cartridge into the AC is very important. If you are doing the wound assisted, it is a different thing, and if you are doing into the AC injection, then the direction of the cartridge is different. Coming to the Visco Wash, always master this. This is very easy. It is not difficult at all. Just push the IOL optic a bit to the opposite side and lift it up with the aspiration port, and then you can just rotate the IOL 3-4 times, and all the visco that is there behind the IOL can be washed. This you should master it. By doing, and you should start this step in small steps, because what you need is a good foot control when you are doing this. You see, multiple rotations can be done and all the visco that is there behind the IOL can be washed. Coming to the wound hydration, if your wound is adequate, just by stromal hydration, your AC will get closed and this will be tight. But if at all there is any leak, you can always check that leak by putting a drop of trypan blue near the incision site and see if there is any fluid drainage. If it is there, then you have to do again hydration, or what you need to do is basically suturing. So as I told you about the incision related technique, so when I told you the length and the width of the incision is very, very important. In this case, you see my side port was too long. Even my incision which I am taking is too long and it is too corneal. So when this type of incisions you have, when you do your procedures, there are a lot of folds on the cornea and that obstructs the visibility and your surgery becomes difficult. So you have to always make sure, you see, the wound goes on hydrating when you are doing the surgery, and you are not able to see the cortex which is there below this edematous area, and this edema has occurred because of longer incision and tighter incision. So then I had to make one more side foot to aspirate the cortex which was there subincisional, because I was not able to visualize it properly. So these are the complications if you are not doing it properly. In this case, you can see I did a rexis. I was overconfident that my rexis is finished. Okay, rexis is finished. I didn't take out the flap. I started doing a hydro, thinking that the flap has come out, and I mechanically, you can say at the spinal level, you just start your surgery. See, I just did the hydro dissection. I rotated the cataract 5-6 times, and I started my phaco. So I am doing the phaco, and suddenly, what do I see? Are you able to observe anything? See, there is a capsular flap which is coming near the phaco tip. So when this capsular flap started coming to the phaco tip, then I realized that the rexis was not complete. So you have to understand that every step is important. These are just a few video clippings of IOL related. If your temperature of the IOL, especially for hydrophobic IOL, is not maintained properly, then there are chances that it might shoot away. In this case, the other video, it tumbled. So I am trying to re-tumble the lens into the AC only and put it in a proper position. It was injected upside down, because when I injected the IOL, it rotated, and now I am showing you the maneuver of how to tumble the lens into the AC without taking it out. Very easy, but you have to master it. So you have to be very observant when you are putting the IOL. So this is another video which I'm showing you how this hydrophobic IOL can behave. Even after you load the IOL, you have to always observe the IOL cartridge into the microscope in low magnification to see that no haptic is getting stuck. You can see in the video on the right side, there was an optic crack. So if you have any of these crack, then you can see in this, the crack is visible. So if you have any of these things, then your surgery becomes difficult because you have to explant these IOLs. So the key to all these steps which I spoke is mentioned in this particular chart. So which all things you have to adapt and how you are going to master. Thank you.
Thank you. Thank you, Dr. Amit. That was really a perfect surgery. Mastering each step individually will lead to a perfect surgery role. Amit, please wait there for a minute. I'd like you to play for Dr. Amit Mahajan. Dr. Amit Mahajan is a private practitioner at Chalisgaon, Maharashtra, but due to certain unavoidable last-minute family problems coming up, he is not able to be present here physically, and he has sent a recorded Zoom video for his presentations, and with due permission of the society, we are playing that presentation. Dr. Amit, please.
Good morning, everyone. At the outset, I will like to thank AIOC, Dr. Amit Porwal, and Vikram sir for giving me this opportunity. I don't have any financial interest. So, these are some of the expressions which we may get in our post-op unhappy patients. So, let me make you one thing very clear, that if you are putting the lenses, you are going to have a patient at some point who isn't happy with the lens. These are the patients who are paying out of their pockets and they pay for the performance. Many times you get that performance, but sometimes you don't. So at times it becomes a sort of tricky pathway to follow, and in this presentation I will be discussing the same. So the first thing is, let's finalize why the patient is unhappy. What exactly is the bothering the patient? And there are only three issues. The first and the most important one is the vision related. Second one is discomfort in and around the eye. And the third is non-specific. So in the vision related issues, mainly there may be the subnormal vision or obstructed vision, or patient may be following some black spots or like arc or glares, or there may be some issues related to the glass dependency. So there are the two possibilities, that if the vision has not improved at all after the surgery, or after some initial happy hours of initial improvement, and later on patient has got tremendous decrease in the vision. So if there is no improvement in the vision, the main causes are mainly because of either the corneal issues or retinal issues, or the patient may be the amblyopic. So in the for the corneal edema, the main causes are the cataract, may be the heart, or prolonged surgical time. There may be some retained fragment, or maybe TAS or DM detachment. So here I want to pay your attention to this very critical entity, that is the retained fragment. So if you have this retained fragment, because what happens that many times during our surgery, small chip of fragment that get little bit hampered behind the iris, and which may come out in the post-op period, and that touches the cornea, and then the corneal edema appears. So here the key factor is to remove that fragment as early as possible. So after initial success, if the vision is decreased, so here the main culprit is mainly the retina. So there may be cystoid macular edema, or irregular rough corneal surface, or raised IOP, or there may be the retinal detachment. So for this retinal and corneal issues, get your retinal or corneal colleague involved at a very early stage. This saves you medico-legally, as well as it creates a good rapport between you and your patient. So for the retinal issues, early OCT is very helpful in detecting as well as to show the patient for the prognosis also. Here again, as per your need, your wearer friend is going to play the critical role. So this obstructed vision, often perceived by the patient as a streaks, dark spots, or glares, arcs, rings and halos, typically crescent shape in the temporal half. These are mainly the dysphotopsia, negative dysphotopsia, positive or diffractive dysphotopsia. And this occurs mainly because of the rays of the light that get diffracted from the periphery of the IOL. But fortunately, with today's modern days IOLs, the phenomena of dysphotopsia is very rare. In any case, if you find that dysphotopsia, mind well that this is a temporary phenomena, and most of the time with the neural adaptation, it gets settled. So never ever attempt any major procedure like lens exchange until and unless you are sure about the dysphotopsia, even after 1 year of the surgery. So don't get in a hurry. Neural adaptation will occur and the patient will gradually decrease the symptoms of the dysphotopsia. Again, the glass dependency depend upon the type of the IOL. With new advent of the trifocals and ADOF, they made our job very easy. But one thing here I want to make you very sure that make sure that the glasses you prescribe and the glasses dispensed by the optician are the same and there is no any error in the dispensed glasses. So discomfort like foreign body sensations, occasional redness, irritation, watering, burning sensation, these are mainly because of the dry eyes, Meibomian gland dysfunctions, or drug toxicity or neurogenic. So, as the dry eyes topic has extensively been discussed by Dr. Saurabh, I won't don't go into the details of these dry eye issues. But here, the success mantra is you always have to think that your vision starts with the tear film. Then comes the non-specific issue. These are sometimes challenging, many times simple, usually infrequent, and typically not so serious type of symptoms. Here, the psychological risk factors like anxiety, depression, fear of surgery, attention deficit should be thoroughly investigated, and if needed, psychologist help psychiatrist help should also be taken. If nothing found, then go for detecting vitamin D3 and B12 levels. Here, so in all these cases, the success mantra is you have to have a plan to deal with all these cases. So before you address unhappy patient, check very carefully that you have got your pre-operative assessment very thorough and very clear, clean. You have got uneventful surgery and you have got bang on target the IOL. So while we make a checklist for the screening of the unhappy patient, the first and the most important thing is the IOP. IOP may rise in the early post-op period as well as in the delayed post-op period. The reason being the different, but you have to check for the IOP. Then check for the residual refractive error. I will discuss about it in detail. Again, ocular surface disorders has been greatly discussed by Dr. Saurabh in his presentation. But the most important thing is that even if you have slightest of the posterior capsular opacification, you may get significant visual disturbances. So if you think of a PCO, get it cleared within after the 3 months of the post-op period. And again, don't forget the retina. So when it comes to the refractive surprises, an ounce of prevention is worth than the pound of cure. So here the first step is to determine what is exactly patient's expectations. Those patients who are asymptomatic and satisfied with the visual outcome may simply be observed. Then those who are amenable to wear the glasses, spectacle correction is the first option. And then comes the lens-based procedures like lens exchange, add-on or piggyback lenses, And in toric, of course, the realigning the toric lens. So when it comes to the piggyback lens, we are having availability like Rainer as well as we are having care group piggyback lenses, and they are having wide range like from -10 to +10 diopter available. So here the advantage is that we can open the original cataract wound for implanting these lenses, easily reversible procedure, and it is very safe even if in cases of PCR or zonulopathy. The formula to calculate is very simple. One can easily calculate it. Complications are least complication, and those complications can easily be manageable. So then comes the Iol Exchange, but here you mind well that Iol Exchange rate was 1.75 during 86 to 90, which has drastically reduced to zero point 0.5 in 2007 to 2011. So wait for at least 3 months and make sure that IOL is the only cause for the patient's visual disturbances. Give trial glasses at least for 1 month. So in this chart, as you can see, the most common cause for IOL exchange is the IOL opacity and not the lens exchange. Then laser refractive surgery is very ideal for error with less than 3 diopter. Here, cornea should be healthy is the only prerequisite. But the limitation is that high residual refractive error we cannot correct, and of course the availability and the cost. Then realignment of the toric IOL, one has to wait for at least 3 weeks. It is very simple and accurate. Either you can go and check on the www.astigmatismfix.com or on iTracy. I have iTracy, and in this case you can see there is only 3-degree rotation. One has to do nothing for such a least degree rotation. But in this case, as you can see, there is 69% of the rotation. So here is the planner which suggests you how much toric lens has to be rotated. So the success mantra is not all refractive misses have to be surgically corrected. So to conclude, let the patient know that you are on the case. You are going to work to get him where he want to. You have to take initiative to follow up and continue to communicate with the patient and maintain the healthy relations. We can use a variety of technology and procedures to make our patients happy. Thank you.
So that was a
Good
pre-recorded
morning,
talk by
everyone.
Amit and
At the outset, I will like to thanks AIOC,
बंद करने को
Dr.
बोलो.
Amit Porwal,
Audio
and
video
Vikram
बंद कर
sir
देना.
for giving me this opportunity.
Vikram. Yeah. So this was a very nicely recorded talk without any disturbance. It was like almost we were feeling he's in the hall and he's speaking it. So thank you, Amit. So now next talk is by Dr. Vikram, our chief instructor. He's going to talk on psychological and emotional elements to manage an unhappy patients. And no one is better than him to answer, to deal with this talk. Why? Because he is a high volume prolific private practitioner practicing in Gurgaon, where you get all sorts of patients, where most of the patients might need a psychological evaluation also post-operative. He has a high experience of handling various type of patients. So I think, Vikram, over to you.
Thank you, Amit. Respected seniors, dear colleagues, good morning. Thank you very much for sparing time on a Sunday morning. The psychological and emotional elements to manage an unhappy patients. You cannot please all the people all the time. The 3 ingredients to brew a challenging interaction in our setup is number 1, we ourselves, our patients, and third, our clinical setup. Each of them have their certain variables which have been mentioned there. And the 3 points of discontentment when interacting with us can happen at all the 3 interaction points. Number 1, the pre-operative, during the surgery, and the most common and the maximum percentage is in the post-op, where we find patients we are not happy with their results. Your system is your reflection. The patient starts forming opinion about you even before he sees you. By the way, how your receptionist talks to him, how he handled as soon as he steps in your setup. Each staff member is very important. Each one has to be competent and efficient. Hospitality is the key word. Your front desk receptionist should always be polite, should be accosting. If a patient asks, is the doctor available, then he or she should be very precise. His time is as vital as your time. Never say the doctor will be there in 10 minutes. Say if the doctor is late on a particular day, the doctor will come maybe around 1 hour later. In the meantime, if you want, you can get your pre-workup done. Never say ki just wait, he'll be there in 10 minutes and then the doctor later comes in an hour or so. That really disturbs the patient. And if your staff has promised we don't know or will get back to you for a particular query by a patient, never forget it and do call back. These are really very simple things, but yes, they help in developing confidence in you and your system. Your waiting area can be very simple. It should be aerated, ventilated, clean. You should have clean drinking water. Basic washroom facilities should be available. That is more than sufficient. Patient don't need more than that, but that should all be clean. Optometrist, who is the first line of interaction with the patient clinically, should just do his work. I find most of the optometrists in setups giving their diagnosis and telling possible treatment modalities. That is not done. Always tell your optometrist, bye, stick to your job. Don't go beyond that. Your junior consultant or optometrist, whosoever takes various questions, should mention those questions in the answers very clearly. Repeating the same set of questions at each station disturbs the patient. Nobody likes to answer same problems again and again. And your counselor should first reach the notes of the consultant before counseling the patient for any particular lens. Few important problems that we encounter here is the patient says, I came before a particular patient, he has already left, but I'm still sitting here. Why? You should be very clear to the patients who are being dilated. Boss, it's going to take you around 1 and 1.5 hours. And do mention you'll have a blurred vision for next 4 to 6 hours. We do get phones in the evening saying, Doctor, what happened? I'm not able to see what I was seeing in the morning. What have you done to my eyes? It does come. This is a very common problem that we face. Then, if you have given an appointment over phone, you should be very clear, yes, this is your time of appointment, but the real waiting period will depend on the ground conditions. Another important aspect, patient says, I came last week, I paid the fees, but I've got no relief. Why should I pay the fees now? This comes up very commonly. In that situation, what we practice is, we just ask once again, the patient says, no, I won't pay. We put the patient in the routine system. He goes to the optometrist, the junior consultant, and then he sees you. By the time he comes to you, he has already waited around half an hour. Then you check him thoroughly. Don't compromise on that. Try and answer all his queries. And before he leaves, tell him, sir, you owe the consultation. Believe me, when you have done your job properly, again, 99.9% patient will pay the consultation. And if there is a VIP patient in your waiting area or another doctor who has come over there for a consultation, never call them by their names. Walk up to them and accost them into your chamber. This will prevent unnecessary mumbling over there in the waiting area. We, healthcare professionals, should never assume the medical knowledge of any patient. I once had a 65-year-old lady, operated well, good post-op vision, 1 month, but she said, I'm not able to read. I said, ma'am, you won't be able to read. You'll have to use glasses for near. She said, why? Aren't they lenses for near? I said, they are. They are multifocal lenses. Then why didn't you tell me? And I was wrong. I didn't counsel or I didn't educate my patient there's something like a multifocal lens. So I lost that patient. And we doctors should be giving appropriate time to our patients. And seriously, attending phone calls during consultation is something which if we be on the other side, we would also never like. So I usually leave my phone at the reception or I put it on a silent mode. These things are really important to have a satisfied patient. The operative part or during the surgery, again, a very important question comes up. I came first in the morning for the surgery. He came late and he's been already operated and sent home. I'm still waiting. Tell the patient, sir, you'll be called around this time. You'll be free around this time. And the sequence is on a very particular protocol which we follow for all our operative list so that patient is not disturbed regarding that. Always check the patient data. Always call the patient by their name before the surgery and tell them, sir, you have opted for this lens. There shouldn't be any irrelevant talks or over a phone talks in the OT. And if anything wrong happens, don't press the panic button, stay cool. If something unfortunate complication happens, the best part is tell to the patient just after the surgery. Don't wait for the first post-op day to explain to him. The patient who walks to you in your OPD is not just an ophthalmic problem. He's the sum total of the medical experiences, past and present, of his and of his relatives for which he has a valid reason. Any visually incapacitating disorder diagnosis can have a profound effect on his life, and he may be disturbed about it. So what psychological strategies you should apply to manage such unhappy patients? Emotional quotient, it is your ability to identify and regulate your feelings and feelings of others around you, something like hypnosis, I would put it. You should always call them by their names, and you should practice the reflective thinking, that is confirming to the patient that you have understood what he's trying to convey. It is like listening and thinking at the same time and conveying it back to him. Keep on listening and understand to the core issues. Approach like the beginner, don't just jump onto the diagnosis or possible modalities of management. Always break down into small compartments the problem so that it can be handled. Practice empathy, that is not getting emotionally involved. Always stay calm. And once you have achieved your target or settled the patient, you have satisfied the patient, it's time to have a break. Still, if a patient becomes irrational and he threatens to call the police or media, you have got all the right to remain silent. Speak less, listen more. The patient may be genuinely in trouble. It could be a cry for help. Venting may help him. But remember, don't tolerate disrespect or foul language. Tell him no conversation can proceed under these circumstances. One very important, patient who will just remember what you have said. He won't realize or remember what bullshit he threw at you. This is very important. And never physically handle or manhandle a patient, never be abusive for a patient. In spite of all this, if the patient still blows up, a simple thing, see, sir, you are under CCTV coverage, can help a lot. Always remember, you are much more learned and sophisticated than him. Image building and maintaining is really important for us. We have to maintain our cool at all the time. Over here, I like to share some of my personal experiences. During one such LASIK patient, I had a buttonholing. The patient had naturally a very bad vision post-op. So by 1 week, he was really disturbed. He's got to be 1 week post-op. He comes to my clinic with his father and 6-7 other men late in the evening. It was time for us to wind up. And then his father was really angry, as expected for any patient's father. And he said, "Doctor, you messed my son's eye and his life." I said, "Sir, I'm really sorry about that. Yes, there's a complication, but we'll manage it and handle it and give us 3 months' time." He said he doesn't have that much time. He has a recruitment next week. Whatever you want to do, you have to do in a week's time. Like I said, I can't do anything about that. You'll have to wait. Okay, no problem. I'm giving you a week's time. I'll coming next week, and I want everything to be fine. So next week, again, he comes at the same time, again with 6-7 people, and it was really when we were all nearly unfinished. I knew he would be coming, but the thing is, you should always hold the bull by the horns. Don't run or escape from the situation. So he again came, same story, everything. They start to shout, and there was no physical violence per se, yeah, but there was a lot of mental abuse. Then one of the patient, the one who had come, maybe he was something, I would say good, that he said, "Doctor Sahab, they have spent a lot of money, they are poor people, they don't have that much money, and the child hasn't got a good vision." I said, "Understand, you refund the money." So I did a refund, I really accept to that, and I refunded the money for one eye, and that is how I saved myself. Though I've lost the patient, and that is, I didn't let the situation aggravate. Another patient had a free flap, and after the surgery, but unfortunately, the marking had diminished by the time I reposited the flap, and so even after I asked another colleague, surgeon over there, to check it whether it's epithelium up or down, but still none of us were sure. I told the patient, "Sir, this has happened." His elder brother who was sitting over there said, "Dekh doctor, kuch ho gaya na mere bhai ki aankh, so you will have it." And these things really disturb you a lot. Then, unfortunately, there were once a series of end-off in my outreach center in the morning. Yesterday, I think just a day before I operated, next in the morning I have a call, "Sir, 2 patients are having end-off." I said, "Just send them over to my center." By the time they came, they were all full of pus. the really bad situation. I know the situation was very bad. I talked to both the patients frankly then and there, sir, we are dealing with a very bad situation. I don't promise you vision now. I just promise to save your eye. And you have got all the right not to have faith in me, because you can obviously already messed up my eye once. I don't have faith in you. In that situation, you are free to go wherever you want to go, get treatment. But then I'm not handling those charges. Yes, I'll do the best and save your eye. I'll whatever comes, and I'm not going to charge a single rupee from you for that. Though there was a lot of shouting over there, but then both the patient relented to take the treatment, and fortunately we could save the eyes. So these are few of the examples that I have been facing. So how to manage unhappy patients? Howsoever good you may try to be and well you may be, but still you can have problems and complaints. Patient always have a valid reason for their problems. You have to validate them, you have to listen to them carefully, and then you have to find solutions to them. Whatever problem is, when the patient, before he comes to you, you see that on your screen or on the sheet that comes to you, the patient is having an issue, maybe he's not having a good vision. What I practically do, before the patient speaks any such thing, I just walk up to the patient and say, boss, had I been in your place, I would not have been happy with this vision. This is not the vision which I would have liked. The patient, taken aback, she says, understands, yes, the doctor knows that everything is not fine. So instead of becoming, I would say, aggressive, the patient just waits and tries to listen. And that takes the first steam out of the patient. And you always provide, once you have said that, you always provide options. It should end up in a discussion, not a quarrel. And then options should be not one, but 2 or 3, which clearly states that, yes, you are under control, you have faced such situation, or you know such situations, and you can handle them. Don't forget to summarize the next step you will take, so that patient knows that you are serious and you are surely going to handle his concern. So, but in spite of all this, sometimes the patient may not be happy or agree to stay with you. And by that moment, you can really understand the patient has already decided to take a second opinion. Always refer him. So, like what I say, your experiences is nothing but the follies that you have committed in your life. Unhappy patients are your greatest source of learning. So, take them as an opportunity to learn something. I know it's not easy while the situation is lasting, it is very tough and it really disturbs you. But if you can practice this, try and handle them positively and stay calm. Thank you. Thank you very much.
Thank you, Vikram. It was nicely summarized and you shared your experiences. We are having only 6 minutes. Just few important points which I want you all to know in your practices. One was what a co-instructor, she mentioned about sac syringing she does in all the patient. So it is your practice. You have to understand whether you want to do syringing for all the patients or you just want to do a Roplast test. So in my center, we do only the Roplast test, and if it is positive or if there is any mild regurgitation of fluid, then we subject the patient for syringing. But with this method, our incidence rate of end-off is only 0.04%. But if you are in a private practice, our patient load is not so much and every patient we are responsible, then I suggest we do the sac syringing. Regarding Saurabh was talking about MGD, I mean, MGD is very common nowadays. So we don't have all these fancy instruments in the OPD to evaluate dry eye. If you don't have all this, how you are going to look for the Meibomian glands? Everybody has an AR. So in the AR, the autorefractometer, you just invert the lid and you will see all the Meibomian glands properly there. So this is one of the way of checking for MGD. Second, dry eyes post-operatively, there are 2 reasons. It's more common in females because of the hormonal changes which are there, and plus for the corneal incisions which we take. So timely diagnosis of the dry eye and treating is very important. This will make your patient very happy. Again, when we look at the post-operative medicine, there was a time when all the medicines were only with bag preservative. Now we have most of the molecules with bag-free. So bag-free molecules really reduces the ocular toxicity. So always do consider for a bag-free medicine. And the most important step with most of them laid out is how your OPD looks. Today, when we go to any consultant's chamber, his hospital, the way the OPD is set up, we know what's the taste of the doctor and we feel how nice, how professional the doctor will be. So always make sure that the OPD setup, the waiting area of the patient is very nicely done. Invest more money on the waiting area and not on fancy equipments which are spoken about, because what you are going to get money is through all this and not to the fancy equipments which you can't reach even the break even for that money equipment. So that's a few important tips which I wanted to say. Over to you, Vikram.
Yeah, just add here, you can see the Meibomian gland even on your slit lamp with the red-free filter. That is in your examination room. And I would just like to invite questions from the audience. We just a few minutes left. Any queries? If we can really.
Actually, I have a question for Dr. Saurabh. Do you add lubricants for all your post-operative patients, or is it mostly as needed?
We add lubricants to all of the patients after 2 weeks of surgery. And because the patient definitely walks into our clinic, they will be asking for some medicines to be instilled for a long period of time.
True, true. The first 2 weeks probably
We don't disturb the tear films. We just we don't disturb the protocols. We just add steroids and antibiotics.
Yeah, and adding on to what Dr. Amit was saying, I always tell my staff that when you walk into the clinic, you must make sure the clinic or the hospital is looking nice, smelling nice, and feeling nice. So it should at least be neat. So whatever we have in the clinic and the magazines or material for the patient, it should look neat. It should feel nice, which means the patient should feel warm when they come in. So the staff should be pleasant and polite when the patient approaches the reception. And it should smell nice. So if nothing else, it should at least not smell bad, So when this is taken care of, your first impression is always good. Even if it's not very fancy, as long as it's clean and neat, it gives a very nice feeling to the patient.
Again, when you're doing the biometry, what she was what I wanted to put a point in this was, if you're doing a contact biometry, and if you're doing it with the patient lying down, the head of the patient, the position of the head of the patient is very, very important. You should not have too much of chin up or chin down. So you should make that the patient is lying supine properly, and then you check the biometry. And use the latest formulas which are available online, and you'll get good post-operative results. What you saw in the talk, the post-operative surprises, our target is to minimize or reduce any post-operative surprises. And most of the time, as a institute setup, what we do is we see the patient in the OPD, he's got a cataract. I tell the patient to I'll tell the sister to dilate the patient, and I'll explain that you have a cataract, you need the surgery. These are the investigations we need to do if you want to undergo the surgery. Because we have a high volume, we can't wait for everything. So the patient says yes, and we start the investigations. So that time already AT is done. So this is what I'm sharing, how we have changed our protocol. AT was done by us, and then the patient is subjecting, he's undergoing the investigation for cataract, which includes the physician fitness and the eye scan. So we have already disturbed his ocular surface, and then we are doing the eye scan. So always make it a habit that if you want to do the eye scan, especially with the premium IOLs, you call the patient some other day, or not on the day you have done all these contact procedures. Or else, if you are using an NCT at the screening, then you can go ahead with your eye scan that day. But if you are doing an AT, never do an eye scan on that particular day, especially if you want to put a toric IOL or a multifocal IOL. So any other inputs, sir?
Yeah. Basically, as a doctor, we should always have a sweet tongue. We should be talking very politely and sweetly to the patient. We don't require a big area. A small practice in a 10 by 10 clinic will give you very good results, because the patient is going to come back to you for your talks. They will feel good if you talk nicely, explain them nicely. And if you have a big elaborate hospital and you're not not very confident enough to talk to the patient and explain them the disease type, they might not turn back. So sweet tongue is what is very important.
See, the time is the most important commodity that we have, and that is the limited. So if you are willing to spend that time with your patient, he also knows that you care about him. So please be willing to spare some time for him.
Yeah, please.
What I've noticed, sometimes we do one eye, and at that time we do biometry of both the eyes, and a patient comes for the other eye after 6 months or maybe later. There is a little bit of difference which is noticed. So what we should go for, the recent one or the...
Amit.
So I always go with the recent one, but I always correlate the biometry which was there 6 months back and now. So you have to correlate the biometry. There might be some changes in the keratometry reading, axial length, but there should not be wide fluctuations. If there are wide fluctuations, then you have to try to analyze why this change has come and try to repeat the biometry by calling the patient again on the next day. Yeah, Suvin, you had a point to tell.
Also check the calibration of your biometer, because that is very important. Sometimes it happens that it might not have been calibrated properly.
Yeah, I have a small comment to add. I don't know if it works in every setup, it works in mine. If what my optometrist does is, when you see the patient first time, the distant direct ophthalmoscopy shows a cataract, any hint of a cataract, specular and biometry is done. And I have the K readings in front of me. So when I am consulting after dilatation, I am already talking of toric IOLs. It's already decided, so it is part of one consultant counseling. You do not go back and nahi, aapka cylinder bhi hai, to thoda sa add karna. So all multifocal and everything is finished by the time patient comes to me. And the best thing is we're charging for every investigation. Only thing, we don't bill them now. We bill them after my consult, saying that, yeah, you are good for surgery now. So we've already done 2 tests. There's OCT's macula has just left. We'll do that. And this is the total bill. Are you willing to go ahead? They're not willing to go ahead. We just done those tests.
Very nice point, Suvin. Actually, this is what I wanted to discuss the next point. Patients usually have a habit of hopping. They do surgeon hopping. They want to know, when you tell cataract, they know, cataract hai, malum hai. What are your charges? What are your packages? The first question is that only. And there comes what Suvin told is very nice, because if you don't have the keratometry, you will start telling them all the packages and they will pick up one particular package and get stuck. So I always tell the patient, let the keratometric, the A-scan result, biometric results come, and then I'll tell you what is suitable for you, and you will have all ranges of from low level, mid level, and high level. But I think incorporating Suvin's things in our practice will help us avoid the waiting time of the patient, reduce the waiting time, and straight away come to the thing that either you need a toric IOL or a multifocal IOL. So that is a very good point which can be embedded.
Yeah.
We just repeat the biometry, don't bill them. We repeat the biometry, even whatever you want to do, repeat. If you want to even repeat the OCT macula, we repeat it. Because the diabetic patient could change status. And we don't bill it. Of course, depends upon the circumstances. The patient is happy to, why not?
But very good point, Suvin. I'm very happy. This, I think I'll incorporate into my practice in Choitram. Thank you. So I think we are finishing the session on time.
Thank you very much. There's a feedback bound there?
No. The feedback for this session is, if you are satisfied in the app, you can just pass a comment in the app that you want what are your feedbacks or comments for this particular session, and that will be taken into consideration while preparing the scientific program. Thank you. Thanks a lot.
Thank you very much.